Good morning and welcome everybody to our webinar entitled To Vaccinate or Not, where we will be demystifying the vaccine, COVID-19 vaccine, by connecting you to one of South Africa's leading medical experts. My name is Untitled Chapter and I will be your host today. COVID-19 has been very topical in the past few months, and there has been competing narratives about the vaccines. This has resulted in many eligible segments of our society being hesitant in being vaccinated. This webinar will provide you with the medical facts about the vaccines. While we are connecting with you online in this way, and it is important to reflect on your own connections and your own connectivity, especially when it comes to your health and financial matters. At Nedbank Private Wealth and Nedbank Financial Planning, we use our globally integrated and advice-led approach to connect your financial decisions to your goals and aspirations. The reality is that every single financial decision we make affects our ability to protect what is important to us and to achieve our goals and objectives. Your money decisions connect your goals, your needs, your dreams, and fears and attitudes, and the role that you play in your community on how you earn, spend, and save your money. We connect you to our technical expertise, a global perspective, appropriate opportunities, and access to solutions and services from across Nedbank and our financial partners. But most importantly, we connect you to the personal and objective advice you need to make your money decision count. And that is what we call connected wealth. Before we get to our topic for today, I'd like to go through some housekeeping with you. On your left-hand side, you will find a Q&A chat box. Please use that to submit your questions, and I'm sure our guests will be more than happy to answer those questions. And if it happens that your screen freezes during the webinar, please press the refresh button and it will take you back to where you stopped last in the webinar. You will also receive an email in the next few days with a link to a recording of the webinar, in case you would like to share this or watch it again. We're very privileged to have Derek Watts and Professor Glenda Gray as our guests today. Derek is a well-known award-winning journalist and a television presenter with 40 years broadcasting experience. Derek will be hosting our conversation today with Professor Glenda Gray. Professor Glenda Gray is the first female president and CEO of South African Medical Research Council. She was the chair of the Research Committee on COVID-19, bringing together scientific evidence and experience to the Minister of Health and the National Coronavirus Command Council. Professor Gray spearheads the South African Medical Research Council funding broadly and for COVID-19 as well. And without wasting any more time, I'm going to hand over to Derek Watts. Derek, over to you.
Zanele, thank you very much, and greetings to our participants, and a very good morning to Professor Gray. How are you this morning?
I'm good.
Busy as always, I'm sure, and the week started on a busy note with your virtual meeting with your counterparts in the UK regarding the red list, and maybe some impressions they had of the beta variant that you updated them on. Just tell us briefly how that went.
I think it was very important to meet with them because it's quite clear that they were behind on their knowledge of South Africa. We have a very sophisticated testing strategy as well as a good strategy to watch the evolution of the virus in South Africa. And I think they were unaware of the depth and the sophistication of our program. And so we had to explain that Delta has replaced Beta in South Africa. And they were concerned about certain parts of the country, and we explained our methodology where we do the random evaluations of breakthrough infections to make sure we can see what's happening with the viral evolution. So we spoke about that. We spoke about the epidemiology of COVID and our testing rates, as well as vaccine passports and issues around how one gets, how one establishes the risk, the robot system, and how often you review it. And also we stress the importance of better communication between the two countries, so that this kind of thing doesn't happen. So we are hopeful that we'll be taken off the red list, and that we can work with them more closely and share our data more easily to improve the assessments that people make of countries. And so I think that was very useful to have that conversation with them.
And this morning's news is the president's getting involved. So we are hopeful, I guess, of that review, which should be in the next couple of weeks. Professor, my wife tells me it's not all about me, but I thought I'd be honest about my approach to the pandemic. I worked on the stories on the AstraZeneca trials, which didn't work out so well. There was the J&J shipment, which was condemned by the FDA. I did many interviews with leading scientists, and they didn't all agree. The stories abounded on the rumor mill, heart surgeons that wouldn't have the vaccine. I mean, we were totally overloaded with information and misinformation, and social media and TV. Even Dr. Fauci seemed to change his tune at times. The ivermectin debate raged, and the rollout eventually started. It was a confusing time, I think, for most of us. And to be honest, I was vaccine hesitant for a few months. But some aspects became fairly obvious. I mean, sadly, friends were dying, and not because of the jab. And I think we've all had that experience. I think hospitals here and in many places overseas were filled, wards were filled, mainly with unvaccinated patients. And on a selfish level, I knew that if I wanted to travel, I would have to eventually get a vaccination passport. Professor, now I know it riles you that there are people who are hesitant, but do you understand that there is certain confusion out there?
Yes, I think I understand. I think there's confusion because people don't think COVID-19 is a serious infection or a serious disease. And I think it's important to note that we are predicting that COVID will outstrip HIV as the biggest killer of South Africans this year. Already 150,000 people, if we look at our excess deaths, have died during our pandemic this year. And so it's very sad in our country. We have a devastating pandemic. We have high fatality rates, and people have died during the pandemic, and it's a very serious condition. You've had friends, I've had colleagues, I've had people who are anti-vaxxers who've died because of COVID, and that's incredibly sad. And so I think the first thing we have to acknowledge is that this is not a namby-pamby virus, and not all of us who get natural infection will survive it.
Professor, let's start with a basic question. Which South Africans over the age of 18 should not be vaccinated?
So I think it's a very important thing to try and understand the risks and benefits of vaccination, and to look at your risk-benefit profile, and talk to your doctor if you decide not to be vaccinated. There are rare side effects of vaccination. One of them obviously is anaphylaxis, and that occurs between 2 and 4 people per million vaccinations. And so if you have a history of allergy, it's important to speak to your doctor and alert the vaccination site about your allergies. And if well managed, you won't have any untoward events. So the vaccination sites are well trained for anaphylaxis, and that's important. The other rare side effects that one might have, and we saw that in the US and in South Africa, was with the J&J jab, which was the thrombosis with thrombocytopenia syndrome, or vaccine-induced thrombotic thrombocytopenia. And if well managed, again, is not fatal. We've had in the Sisonke study, we had we had three cases, and they were well managed and were not fatal. That's important. We've had also, I saw in the media and in South Africa and reports abroad of a Guillain-Barré syndrome. Again, if people have early, if it's detected early and well managed, these things are also not fatal. We've also heard of reports of, particularly in younger people and men with the Pfizer, the myocarditis and pericarditis, but these are all rare. So a lot of these events these rare events that I'm talking about occur between 4 and 8 per million vaccinations. And so if you're concerned about that you have a predisposition to thrombosis, or you've had a DVT or pulmonary embolus before, you can work with the hematologists who will guide you through your vaccination schedule. You also have to remember, if you've had a DVT or thrombosis or pulmonary embolus before, and you get COVID, you're at incredible risk of having really adverse events following your COVID infection. And so people with clotting predispositions need to work with their doctors and the vaccination center to make sure that they feel confident about being vaccinated. We have a hematologist on our program that we work with, and if there's any concern, we discuss things like anti-clotting agents 3 days before vaccination. But we don't suggest you do this by yourself, but that you work with teams and hematologists if you're worried about any side effects. So if you are worried about a side effect, or you have an existing ailment or disorder that you think is going to interfere with the vaccination, it's important to speak to experts and let them guide you through it, and not you make your decision by yourself.
Professor, is there a red flag for those who are HIV positive, especially if they're not on antiretrovirals?
So we are concerned about effectiveness of vaccines in immunocompromised people. So we do know that people who have had organ transplants or are immunocompromised or HIV infected may need additional boosting or may need additional doses. So the vaccine effectiveness may be lower if you're immunocompromised, and maybe lower if you're HIV infected, particularly if you're not your CD4 count or viral load. If your CD4 count is low and your viral load is high, and you're not taking your medication. So we do want people who are immunocompromised to be vaccinated, because they're even more at risk of dying from COVID disease, and so they're critical to be identified and be vaccinated. We in Sisonke, we had HIV infected healthcare workers who were enrolled, and we found that the vaccine was effective in that group, albeit slightly lower than a young non-immunocompromised person.
There was concern that some people who are HIV positive could harbor the virus for an extended period and be spreaders in that right. Any truth to that?
So any immunocompromised person, if they're HIV infected or if they've got cancer, we've seen this in the UK, people with cancer, maybe chronic spread, they maybe have chronic infection and may have chronic shedding, what we call chronic shedding. So you still have the virus in your nose and you shed it. And in immunocompromised individuals, you may find that viral evolution may occur, particularly with chronic shedders. And so we are concerned about people who are immunocompromised, because they may lead to viral evolution, because their immune system is interacting with the virus and it's not able to manage it and clear the infection. And so therefore we're at risk of viral evolution in those people.
So it's something that is being watched and researched. Professor, some questions from our Nedbank audience and others. Quick Q&As. Are all vaccines safe for pregnant women and breastfeeding mothers?
So if you look at the WHO recommendations and the associations for obstetrics and gynecologists, they will recommend vaccination of pregnant women and lactating women. And in South Africa, we also recommend it. Pfizer has been well researched in pregnancy and breastfeeding, and is used at a global level. We have also been evaluating the adeno 26 or the J&J jab in pregnant women, in pregnant healthcare workers, and are following them up. And so we do recommend that vaccines are critical for pregnant and breastfeeding women, because women who are pregnant have adverse outcomes if they get COVID. And we have seen that at a global level. Women who are pregnant are at risk of adverse outcomes for COVID. And so therefore, it's important for them to be protected. We recommend normally vaccinating after the first trimester and before 36 weeks of pregnancy. But we do see it at a global level that a lot of women are being vaccinated, and it's recommended given the risk-benefit ratio of having COVID when you're pregnant versus being vaccinated.
Professor, another question from a viewer. Is it true that we will only know after 2 years of being vaccinated if the vaccine has a negative effect on your body or not? Interesting.
Yeah, I think it's important to understand how vaccines work. So when you have a vaccine, it goes into your arm, your immune system develops an immune response to it, and the vaccine itself degrades. And usually we don't see any side effects after 28 days. Okay. But we continue to observe, particularly in the Sasonki, we follow up participants for 2 years to try and evaluate if there would be any side effects. But if we compare this vaccine to other vaccines, it's hard to imagine what the biological plausibility would be for a condition to emerge 2 years after taking a vaccine.
Professor, I think you've really answered this one, but I'm throwing it in. Can the vaccine compromise your fertility?
I have not seen anyone with that, and it'd be hard to know what the biological plausibility would be. So the vaccine goes into your arm. It induces immune response, humoral and cellular immunity, and it would be what would be the mechanism? It's also important to know that these vaccines also do go through preclinical testing in animal studies, and they do what we call a reprotox studies, and look for any red flags. And this has not come out even in the preclinical. So it would be difficult to understand what the biological plausibility would be to making you infertile if you take a COVID vaccine.
Thanks for that, Professor. Now, Pfizer has researched the use of the vaccine for 5 to 11-year-olds and are submitting the findings to the FDA for, I think, emergency use authorization. What's your response to that?
I think it's very important to get our children vaccinated. And we've seen that children in the US, in Europe, in France, in Malaysia, in Singapore, in China, in Chile, have been vaccinated. And they've used Sinovac as well as Pfizer. And so Pfizer is being used in the US in children over 12. And there have been studies in other parts of the world in younger children. And in fact, in South Africa, we are also evaluating the Sinovac vaccine in young children. And so it's very critical to keep schools open, to protect grandparents, and to protect children from COVID. It's important to get them vaccinated. So children should be the beneficiaries of vaccination. So whatever we find to be effective in adults, we should make sure that children are also beneficiaries of these life-saving interventions.
We do have a question. When will 12 to 18-year-olds be able to have the vaccine in South Africa? Is it possible for you to answer that?
Well, I'd hope by early next year. And I think they probably would start with the 16 and 17-year-olds to protect the matric year and then move downwards. It's all about vaccine supply and going to the most vulnerable first and then working your way down as your vaccine supply gets secured. And so I would like to see a case where 12 to 18-year-olds are vaccinated, and then to move down, and obviously for the EPI program, hopefully one day, if you start with the vaccination right at the time of the other vaccinations we give children, it would be a good way of ensuring that we start to take control of SARS-CoV-2 right from the beginning.
Well, Pfizer expects their trials for infants as young as 6 months old to be available later this year. Some of us might be shocked by that, but I think in your world-renowned work in HIV, it can start with toddlers. We shouldn't actually shy away from that. Am I right or wrong?
I mean, vaccinations, we use the primary beneficiaries of vaccines have been children. And there's no reason why COVID vaccines should be withheld from children. And once we see the data from Pfizer and other vaccine pharmaceuticals, we could start having our own determination in